All right, everybody, let's talk DBT, the moment you've been waiting for. In this first video, we're going to talk about the theory of change. So let's dive into that. Remember, the theory of change is how a person progresses from when they first enter your office to the time they leave their office, hopefully improving. And what is it that brings about that improvement? That's what theory of change means. And that's something that I want you as students to be able to talk to and explain, not only to clients, but to other counselors and clinicians out there. If you were ever asked, what is the theory of change, or what is it that causes clients to progress through a certain modality, you should be able to speak to it. So let's dive in. The first part of the theory of change begins with the therapeutic relationship. This was always very important to Marsha Linehan from the very beginning, as this theoretical model was developed particularly for those with borderline personality disorder. She realized early on that having a strong therapeutic alliance is central to DBT. Now, this therapeutic alliance goes hand in hand with validation. She found very quickly also that validating clients' experiences, acknowledging their feelings and perspectives, doesn't always mean you have to agree with them, but at least acknowledging and attempting to find out and figure out where they're coming from is also a crucial part of DBT. That validation that their experiences are real to them, and they don't always have to kind of be true in the sense of condoning or agreeing with them. Number 3, so dialectical dilemmas. Now, this obviously is part of the name of dialectical behavioral therapy. Dialectical dilemmas are these situations that Marsha Linehan describes as kind of where opposites or seemingly opposites conflict with emotions, desires, needs, and that clients and the general public faces every day with different oppositions in our lives, and we need to choose between them. Now, it's creating this synthesis is what DBT is all about. It's starting to recognize and becoming aware of opposites or dialectics, and then learning how to synthesize and make wise choices when we're faced with two seemingly different opposing forces or emotions or desires, beliefs, whatever that may be. Dialectics come in all forms, but learning how to synthesize those rather than always looking at them as extremes or mutually exclusive is part of DBT. It's bringing people to the middle, which then leads us to dysfunctional assumptions. This is where DBT evolved from CBT. Now, there still is this lingering portion of CBT that has to do with dysfunctional assumptions. This really is kind of the old school idea that individuals with emotional dysregulation still hold what early on was called cognitive distortions, cognitive errors. Marsha Linehan describes it as kind of dysfunctional assumptions that have to do with themselves, others, and the world around them. So DBT still has that grounding in trying to help clients with what we would call cognitive thinking errors or cognitive errors, and helping them to understand how that shapes and influences their perception. All right, part 2. Let's dive into this. So part 1 talked about those elements of theories of change. Theory of change part 2 is a little bit more of the technical side of the theory of change. So this comes down to, for example, theory of change of hitting the hierarchy of targets. Now, this is, of all the modalities that you'll explore out there when you get into your careers and as you go through the remainder of your school, DBT is one of the more linear and one of the more structured modalities that you'll find out there. And that has to do with these targets that DBT attempts to hit with clients before they're able to move or progress through DBT. So the theory of change with DBT very much is a linear process, although Marsha Linehan admits that people can circle back around. And yet, for the most part, proceeding through these targets and stages is critical to understanding the theory of change, and also learning how, as a clinician, to assess and evaluate whether a client is progressing. So the first target of change, or the hierarchy of targets, is the most life-threatening behavior. So in DBT, they are focused on behavioral changes that have to do with life-threatening behaviors first, such as suicidal attempts, suicidal ideation, even suicidal behaviors. All of those things DBT really targets first and foremost before anything else. They don't even move on to really approaching anything else until that first hierarchy is taken care of. Now, later on, we'll explain here in a second what those other hierarchies are, but the important thing to know is the most life-threatening is the very first target. The second ones have to do more so with emotions, quality of life, and then eventually kind of really functioning at a much higher self-actualized target. Number 2. So as I explained in the previous slide, DBT is still based in definitely some of the cognitive aspects of the original CBT. The second wave, DBT the pendulum kind of swung over to saying, hey, we can't forget about the behavioral principles. Marsha Linehan herself admits that she was very much grew up in the clinical realm focused on behaviorism and behavioral changes. And so DBT really focuses on incorporating behavioral principles to bring about change. Yes, the cognitive errors and the cognitive distortions are important for clients to understand, but she also realizes that clients need behavioral skills and behavioral changes in order to progress. So DBT really focuses heavily on the behavioral side of change. The next one is skills acquisition. So this builds on this previous point, which is in order to bring about behavioral change and target behavioral principles, clients need skills. And that's Marsha Linehan's big thrust in DBT, is that clients need the skills, behavioral skills, in order to address the thoughts, the feelings, and behaviors that they're struggling with. That clients just can't be left to hopefully find insight to change. It's clients need tools in order to help create the change. So DBT talks about 4 specific modules of skill acquisition. Those range anywhere from mindfulness to interpersonal effectiveness, emotional regulation, and distress tolerance. Those are the 4 modules of DBT in which all of their skills end up, falling under those categories. Now, mindfulness, even though it's part of the 4 modules, mindfulness is really kind of also what made DBT a third wave CBT framework. This integration now of mindfulness, this kind of Eastern philosophy and increased awareness of thoughts, emotions, and behaviors. And this idea of also mindfulness being the ability to observe in a non-judgmental way. That's what really mindfulness is to DBT. It's awareness, it's being in the present moment, and to do so in a non-judgmental way. So being able to observe thoughts and feelings without placing judgment on them. That's a key part of DBT. And then finally, the stages of treatment. This really relates back to the hierarchy of targets. Now remember, targets are a way for clinicians to evaluate a client's progress. The stages of treatment also are kind of another way to frame that, in saying that DBT is delivered in a series of stages. And I'll follow up that with a different slide here in just a little bit. But DBT is developed in stages. It has at least 4 stages, but there's also kind of an interesting one called pre-treatment, even prior to that. So the 4 stages are as follows. So let me just jump right in. Stage 1 has to do with, if you think of it as this diagram here of a house, stage 1 is kind of the house is on fire, meaning These are the life-threatening severe behavioral dysregulation that is the target of hierarchy. That first target is clients need to be stabilized. They need to focus on, let's put the fire out, so to speak, that severe level of dysregulation before anything else, before you even can progress up the stages. So it's getting clients to no longer participate in, or to at least stabilize in no longer having life-threatening behaviors. That could include suicidal behaviors, gestures, ideation, or severe behavioral discontrol, and that could be such things as severe addiction to the point where that person's not able to function. So that's stage one. To the right here, you see behavioral control is really kind of the clinician's target, and over to the left is really kind of what the client is working on, and usually kind of what the stage is all about. So stage one, severe behavioral discontrol. To the right there, the client or the clinician is really working on behavioral control. Stage two, the client comes in, it's this kind of quiet desperation. That's, I would consider, kind of moderate to severe depressive symptoms, moderate to severe anxiety. That could be PTSD symptoms, trauma symptoms. There's kind of the deeper emotional disruption within the individual that's causing a lot of issues with functioning. Over to the right there, emotional experiencing is really what the clinician then is focused on, is how to begin to experience and sit with those emotions, and not let the emotions kind of drive their behaviors, which usually then has led to stage one, kind of being in constant crisis. Now to the left-hand side on stage three, that's usually problems of living. At this point, clients have progressed far enough to where focusing on day-to-day living is more of the goals for the clinician. So you're looking at kind of balancing happiness, unhappiness, what's kind of this normal ebbs and flows of life, and what are some of the problems of living, which could include interpersonal issues maybe at work or at home that don't rise to, or don't kind of get to those deeper emotional levels that lead a client to emotional dysregulation. Nonetheless, stage three still is getting clients to move in the direction of higher functioning in a day-to-day living. And then finally, stage four kind of came around a little bit later with Marshall Linehan. This is similar to kind of Maslow's hierarchy, where the top portion of the hierarchy was kind of later developed as, I imagine she found that, just dealing with problems of living wasn't necessarily the end stage, that she felt that stage four, over to the left, of clients then feeling kind of incomplete. What's their sense of purpose? What's their sense of connection to society, to the universe, to the environment? And so in the stage four, which is the highest stage then, is the clinician is working on this capacity for sustained joy, this kind of deeper sense of peace, contentment. Marshall Linehan uses words such as spirituality, or kind of this existentialism of this greater connection. So these are the stages of DBT from 1 to 4. This next slide goes a little bit deeper into the stages. It leaves out stage 4, which I just covered, mostly because, again, it's really considered quite a ways down the road in normal kind of DBT practice. This slide, though, does cover an interesting stage that wasn't addressed, and that is called pre-treatment. Now, pre-treatment usually lasts about 4 weeks. This is a critical part of DBT, because this is where the client is really oriented to what DBT is and what's required of DBT. Of all the modalities that I've researched and explored out there, DBT also is one of the modalities that needs clients and wants clients to commit to fidelity of going through this treatment and sticking with treatment. And so they spend this pre-treatment time identifying goals, orienting clients to what it's going to require. They're trying to use kind of motivational interviewing skills to enhance the motivation and commitment to staying with the treatment. This usually begins with individual consultations and as well as DBT consultation teams between the clinician and the staff of DBT therapists to decide whether that client is ready to enter treatment. Once it's decided, once that client's ready to go, they then proceed to stage 1, which I just addressed in the previous slide, where the target, the hierarchy of targets, is definitely focused on life-threatening behaviors, serious therapy interfering behaviors. That's a key phrase in DBT. Anything that gets in the way of interfering with therapy is considered a therapy interfering behavior, in this case serious. So this could include severe kind of drug or alcohol or substance use. This could include suicide attempts. Things like that are considered therapy interfering behaviors because it gets in the way of treatment and attending counseling, individual counseling, groups, all those things that are required. And then finally there it shows what interventions are involved in each stage. So just to, if you look at this slide here, stage 1 and 2 are very much the same. We're talking about individual treatment, skills training, which has to do with groups that they attend, phone coaching, and then DBT consultation. Stage 2, once they get a hold of and stabilized over life-threatening behaviors, stage two is symptom reduction. So we're talking PTSD, trauma, eating disorders, anxiety disorders, mood disorders, all of those things that can be highly emotional and deeper emotional issues within the individual. That's the stage 2, where they're really taught a lot of skills of emotional regulation, distress tolerance, all of that. The interventions very much are the same as stage 1. Finally, stage 3, as I mentioned, this is where regulating emotions mostly through acceptance and change, really focusing on quality of life, self-esteem, relationship issues. This is stage 3 of DBT. It does continue to involve group skills training and the clinician working with the DBT team. But at this point, individual counseling isn't really the focus of DBT. It's mostly continuing to attend to groups and implement skills. The last slide of this video is speaking to the 4 components of DBT that I just covered in the previous slide. This just is a nice way to break it out into what the time commitment for an individual might be who is following a DBT to fidelity. Now, most programs, I would say it's pretty rare to actually find an agency or a program that follows DBT to fidelity unless it's some sort of inpatient or intensive outpatient or day treatment sort of program. Otherwise, most clinicians in some sort of private practice really, I'll be honest, don't have really the time and the means to carry out DBT to fidelity. A lot of it is not, you're not really able to bill it. Plus it requires a lot of time. It requires different staff. For example, 1 hour of individual therapy, that's reasonable, obviously. But then we come to the second component, which requires group skills training of at least 2.5 hours a week. So can you imagine, 2.5 hours, that's likely broke up into, 2 different groups perhaps during the week. So clients would have to commit to at least 1 individual session, 1 group, if not 2 group sessions. Then the therapist would have to consult with a DBT team for about an hour to an hour and a half, and then phone coaching on top of that. It's important to mention that phone coaching is only as needed, and it is explained to the client that this is coaching. This isn't a crisis line. So if a client reaches out to the therapist or to the coach, it is merely to address what is the current circumstance and then to coach the client through it by applying the skills that they've learned to then help them emotionally regulate or implement distress tolerance skills to lower the temperature of what they're going through so that they avoid going into the hospital or avoid some sort of life-threatening behavior. But that's what phone coaching is. It's not a crisis line. It's not meant for an additional session. and clients are oriented to that right from the get-go. So there we go. That's kind of the inner workings of DBT in this particular video. The following video is really going to go much more into the concepts and foundations of DBT. So we'll see in the next video. Thanks.